Okay, well, it's my pleasure to introduce the very last session of our meeting, which is a first for us as an organization, something that's been very popular in your local areas as well as other meetings, which is the chance to give uh, our presenters, particularly our young investigators, the chance to come up to the front and to highlight their work, even as it's a very short update. And so this is the rapid fire abstract session. Um, my name is Suhail Hussain. I'm from Stanford University, and I'm joined by Dr. Chamini Perara, who is a senior scientist at the University of New South Wales in Australia. And I just want to introduce you to this session, which will have a series of speakers. So please also don't feel fatigued. This is really meant as a high-level update of work. So we have roughly about 17 speakers. Each of them will be given 3 minutes, and then we'll have 2 minutes for Q&A. Now, we really need to be strict, and so please, if I come off and we come off as being somewhat draconian, it's only because we need to keep it to time. We also want to let you catch your flights potentially on time. And so at 2.5 minutes, I believe that you should see a yellow light. We'll keep a timer on as well, and we'll do a double knock at 2.5 minutes. At 3 minutes, you should hear a large sound from us in the chimes. And then that really means that you have to end. If you're still ongoing, we may come up and nudge you along. And then for the Q&A, please, short questions and short responses. And with that, I'm going to pass to Dr. Shamini.
Thank you, Dr. Sohail. So our first speaker for the session today is Dr. Slavika Tatarova from UCLA.
Good morning, and thank you for the opportunity. Half of all PDACs co-occur with diabetes, and yet diabetes is not just a simply coexisting disease. It's a major metabolic, pro-inflammatory, and hormonal perturbation, for example, marked by hyperglucagonemia in type 3C, posing the question of whether or not diabetes can sculpt a clonal niche in PDAC, which is relevant for its therapeutic targeting. We investigated pancreata of PDAC patients and found in diabetics that lactate receptor GPR81 positive ductal-like cancer cells doubled in proportion. Moreover, they co-clustered with diabetic islets, which were metabolically remodeled and cytokine-rich, proposing that islet secretome rich on lactate and cytokines may mediate the crosstalk. We asked what is the feature of these GPR81 positive tumors and found they sit in a fuel-rich and yet immunoquiet niche. We substantiated it with spatial immunoprofiling that indicated skewed type 2 immunity and fewer cytotoxic T cells. That was further reflective in an immunoevasive transcriptional signature of GPR81 positive PDAC. Now, morphologically, GPR81 ductal cells were enriched for glandular morphobiotype with increased features of CEACAM, APCAM, mucin, and cadherin, and together with transcriptional factors, conveyed a differentiated, highly secretory, epithelially locked state. Now, transcriptional analysis through spatial transcriptomics indicated very specific metabolic preference shift towards increased utilization of fatty acids and linking it to increased leaning to OXPHOS modules, while at the same time at the expense of proliferation and glycolysis, which were reduced. Now we ask, how is this metabolic preference transcriptionally regulated, and found with bioinformatic analysis of spatial transcriptomics that at the core there is this MODY1 but also MODY3 related anchor transcriptional network that probably implements lipogenesis with increased dominant PGC1 alpha module that reflects responsiveness to glucagon CMP and that beautifully aligns with hyperglucagonemia in type 3C. Tumor areas enriched for MODY and GPR81 likely deprive the microenvironment from, in particular, fatty acids, explaining potentially how PDAC lesions may lead to further deterioration of islet pathology in type 3. Now, GPR81 is not only distinct phenotype, but also it is a actionable one, and we propose targeting 3 separate axes: metabolic anabolism, reigniting immunity, and very importantly, targeting PFKB3 to disrupt the metabolic loop that sustains this niche. With this, we believe that we will be closer to designing a strategy for precision medicine of PDAC in context of diabetes. I would like to thank you, all the lab members, collaborators, and the funding, and happy to take your questions on.
Lavika, thank you very much. Great presentation. Is that receptor present only on ductal cells, or do you think other immune cells and or stellate cells or fibroblasts might also, you might get an increase in the effect, a therapeutic effect if you target it?
So far it is known that it has physiologically is implicated, its expression in adipocytes in brain and muscle. And yet we see specifically in context of diabetes to be increased in ductal cells in PDAC patients. We have not looked at other, but it is very valid question, and that's what we are going to check.
Any further questions from the audience?
Right, thank you very much.
Thank you.
Our next speaker is Dr. Petr Vanek. Oh. Oh. Oh, sorry. So Dr. Yang Chen from MD Anderson Cancer Center.
Thank you. Truly an honor to have this opportunity to share with you some of our work. Especially, I'm grateful and honored to receive this year's APA Young Investigator Grant, which will tremendously support the research project I'm going to share today, working on TREM2 in pancreatic inflammation and cancer. So when I was a postdoc, I worked on studying the distinctive roles of type 1 collagen in pancreatic cancer. And I found out that the type 1 collagen as the most important stromal component can significantly alter the immune microenvironment, especially tumor-associated macrophages. And TREM2 was one of the key marker gene highly expressed by a significant proportion of tumor-associated macrophages. That's when I became interested in studying it. So that's why 3 years ago, I started my lab, and then I did a lot of work, several different projects working on different subtype of the tumor-associated macrophages labeled by galectin-3, as I reported last year, and as well as TREM2. And the TREM2 has been reported as an important immune regulator for macrophages, and in some context, like let's say some cancer types, TREM2 has been reported to be immunosuppressive and tumor promoting. However, in other cancer types, it has been reported to be tumor restraining. That's why it's highly context-dependent mechanism for TREM2. And in pancreatic cancer, it remains unknown whether it's promoting or restraining. So that's why first thing I purchased the TREM2 whole body knockout mice from Jackson Lab, crossed with the KPC mice to study the TREM2 function in the context of spontaneous pancreatic tumor formation. And then surprisingly, we found that TREM2 knockout actually accelerated the tumor progression. And to make a long story short, we found out that when we depleted TREM2, indeed we got inflammatory macrophages. However, those pro-inflammatory macrophages do not necessarily equal to anti-tumoral macrophages. So those macrophages with the lack of TREM2, they highly upregulate NF-kappa B inflammasome pathway, leading to the upregulation of IL-1 beta secretion, which will fuel the pancreatic inflammation as well as the tumorigenesis. Which this study was published this year in Gastroenterology. And More importantly, we found out that it seems that our findings in pancreatic cancer may also be applicable to chronic pancreatitis context. For example, we analyzed the human chronic pancreatitis single-cell RNA sequencing database published by Dr. Baomi Li and colleagues, as shown here. We can see that in TREM2 is low and IL-1 beta is high in the macrophages in pancreatitis. So somehow they are linked. We are working on this thanks to the funding support.
We have time for questions.
Okay, so we'd like to invite our next speaker, Peter Van from University of Minnesota. Thank you.
Okay. Well, this is a really rapid session, so thank you. I'll present our study on mission predictors of who can be safely managed conservatively in necrotizing pancreatitis. Up to 20% of acute pancreatitis cases develop necrosis, but their trajectories differ widely. Some patients recover with supportive care alone. Others deteriorate and require drainage or necrosectomy. The challenge is that on admission, we cannot reliably distinguish these groups. Yet up to 70% of patients in large series undergo some sort of interventions. A simple way to identify safe candidates for conservative management would meaningfully guide monitoring. Our objective was to determine which admission level features predict a wholly conservative course in necrotizing pancreatitis. We analyzed a prospectively maintained cohort from 2009 to 2022. All patients had early CT within 72 hours of admission, and conservative management meant no intervention during the entire disease course. We adjusted for severity markers and imaging features in a multivariable model, and radiologists were blinded to outcomes. As you can see, of 512 patients, 30% or 155 patients were managed truly conservatively, while 357 required some type of intervention. The intervention group more often had infected necrosis, larger collections, and pancreatic duct disconnection. Notably, 77% of interventions occurred during the index admission, indicating early clinical deterioration in high-risk patients. 3 admission findings independently predicted a conservative course. Sterile necrosis was the strongest predictor with an adjusted odds ratio of over 8. A collection under 6 centimeters increased the odds of conservative success nearly 6-fold, and intact pancreatic duct anatomy doubled the likelihood of avoiding intervention. Clinically, these findings stratify patients into high and low risk groups. Those with all 3 favorable features generally remain intervention-free. In contrast, having even one adverse feature, infected necrosis, a large collection, or a duct disruption, means roughly 8 out of 10 will ultimately require an intervention. This produces a clinical actionable triage model. In summary, sterile necrosis, smaller collections, and duct integrity on the admission CT identify patients likely to succeed in conservative management. And these simple variables can help personalize monitoring intensity and avoid unnecessary treatment. Thank you.
Nice study and congratulations. Can you describe how you blinded the radiologists, what the process was?
Yeah, so the radiologist, we had a group of 3 radiologists basically working on consensus. They were blinded to the patient outcomes and their clinical trajectory. So they were blindly assessing the CT scans retrospectively.
So these CT scans did not have identifiers on them?
No. Yeah.
Thank you.
Thank you.
Our next speaker is Dr. Geeta Sarunya from the University of Minnesota. So who's do we have currently? Okay. So sorry about that. Just one technical thing. We've got 2 different schedules. Shall we go with the one that's printed out here? Right. So let's go with the slides, but which ones are the slides is the question. Okay, great. Thank you. Okay, so apologies. Our next speaker is Dr. Gaurav Suryawanshi from the University of Minnesota. Still University of Minnesota.
All right. Hi, everyone. My name's Gaurav Suryawanshi. I'd like to thank the APA and the moderators for allowing me to present our group's work. So the understanding in acute pancreatitis is that early oral refeeding preserves gut barrier integrity and attenuates systemic inflammation, reduces complications, and shortens length of stay. In our project, we define oral feeding intolerance, OFI, as the recurrence of pain, vomiting, or failure to meet caloric targets that requires escalation to enteral or parenteral nutrition. And however, despite its prognostic importance, we currently lack tools to identify those patients who cannot tolerate oral feeding. One of the prevailing thoughts in the understanding of acute pancreatitis pathophysiology is the role of cytokine overload or release in driving inflammation. And, through inherent lipotoxicity, we understand that patients with increased visceral adipose tissue may have an increased seat for cytokine overload, which then in turn drives inflammation and leads to adverse outcomes. So for the purpose of our study, we utilized a grading system initially proposed by the research group in Chandigarh, India, at the Postgraduate Institute of Medical Education and Research. And they graded CT scans based on the following criteria. Picture A, or type 0, shows no changes in the mesentery. Picture B, or type 1, shows vascular engorgement and focal fat stranding at the root of the mesentery. Picture C, or type 2, shows diffuse mesenteric fat stranding without mass effect. And picture D, or type 3, shows diffuse mesenteric fat stranding with mass effect to adjacent structures. So the purpose of our study was to evaluate whether severity of mesenteric changes on index CT scan predicted independently OFI. We had an adult patient population from 2019 to 2023 that was identified from a prospectively maintained database. They had a diagnosis of AP by Atlanta criteria and had a CT between 3 to 7 days from pain onset. Patients that had a non-diagnostic CT or had a withdrawal of care before feeding attempt were excluded, and then univariable and multivariable analysis after purposeful selection with a p-value of less than 0.05 was considered significant. 285 patients out of a cohort 500 met our criteria, and 34 had developed OFI. And of those 34, 29 required enteral nutrition, 3 required enteral and parenteral nutrition, and 2 required just parenteral nutrition alone. The median time to initiation of total or enteral nutrition, parenteral or enteral nutrition was 5 days. When we account for sex, age, etiology, and BMI, along with ASA and BISAP for comorbidities as well as severity, we find that severe mesenteric changes on index CT independently predictive OFI with an adjusted odds ratio of 6.9. Here we show that with increasing mesenteric changes, they are associated with important clinical factors such as ICU stay, persistent organ failure, as well as length of stay. So why should we care? Well, it allows us for personalized nutrition planning. It will allow us to improve patient counseling for patients before, after, and during their admission, risk stratify patients and understand who might develop comorbidities, and then finally allow us to utilize hospital resources optimally. And these are some future implications of our study.
Is it now open?
Cheers. Would it be of value to measure lipopolysaccharide in the blood to verify that the barrier is being protected?
I certainly think so. We didn't do that for our study, but I think that's an additional component that can be added to the imaging findings that we have and seeing if that is significant. Absolutely. Thank you. Thank you.
Thank you. So our next speaker is Geeta Sarunya from University of Minnesota.
Thank you very much for the opportunity of the podium. My name is Geeta Sarunya, and I'm an clinical research professor at the University of Minnesota. I'm going to talk to you a little bit about the modeling that I've been working on. So we know that there is variability in recovery outcomes post-surgical interventions and through post-TPI, T2. And we have seen that all the traditional analyses that we look at for biomarkers and any kind of studies tend to look at single outcomes. But the recovery trajectories are multifactorial and dynamic. So there's a need to build models that are more cohesive and can integrate all of these multiple outcomes together. So to address the gap, we ended up building a GRE-based autoencoder that takes in multiple outcome variables of pain intensity, opioid use, physical function, and to generate latent recovery embeddings to build recovery trajectories. And we did that on the post-data cohort. We were able to identify 3 reproducible phenotypes, which we categorized as high, mixed, and low responders. And as you can see, they tend to separate out pretty well across our patient cohorts. And in order to see if this particular model provides clinically meaningful information, we analyze the recovery trajectories across the individual variables that were used. For the pain scores at 12 months post-intervention, we can see that the high responders definitely had a higher improvement at least 3.5 point drop as compared to the low responders. The opioid usage decreased for the high responders, but for the low responders, as you can see, there was almost a 3.5 points increase. And the PCS scores, the quality of life definitely showed improvement across the trajectories. So the previous slides showed at individual endpoints when we were trying to show what does it look like across the period of time. And here we try to combine multiple outcomes together through an alluvial model. And you have some of the patient cohorts that have moved from one clinical phenotype trajectory to another across the period of time. So what are the key takeaways for this analysis? The cluster membership at baseline can predict your up to 36 month of outcomes. There is a graded response pattern, but there is a limitation of the model as is. It is a prognostic and not a causal model because of residual confounding, as we have seen through all the talks. There's severity, treatment selections, etc. And of course, there is patient attrition. So some of the next steps, we are going to be including tracking phenotype evolution and building it neighborhood maps to identify context-specific improvement conditions within these clusters. Thank you very much.
Thank you so much. You showed in your algorithmic pipeline, you use also encoders. And so do you predict based on the clinical presentation, what would be the outcome? You show here the predicts 6 to 36 months, but
Yes.
like you showed other time points also in your presentation.
Yes. So are you asking if the variables are the same that we used within the part of a model?
Yeah, and also do you try to predict the outcome like for the all time points?
Within the patient cohort, yes, we did. And we kind of divided the patient. We had about 384 samples, and we kind of did it at an 80-20 split and ended up predicting, and we were able to predict the outcomes. The graphs that I showed was a combination of a test and a training cohort.
Okay. What is the AUC?
The AUC, this is not a prediction. Oh, okay. So I see what you mean. Our AUC for the individual predicted model, we did not carry out for the post cohort only because of the fact that we were mapping the phenotypes and that wasn't the
Okay.
goal, but we are trying to do it for a different cohort.
Okay, thank you.
Thank you.
Okay, our next speaker is Krishna Kumar Samaga from Nationwide Children's Hospital.
Thank the organizers for this wonderful opportunity. As is known in the field, the islet isolation process uses enzymatic as well as mechanical approaches to digest the pancreas. And this severs the vascular connection in the islets, resulting in hypoxic and metabolic stress, which leads to poor islet graft survival. Our team is trying to develop strategies to enable rapid revascularization of the islets using pancreatic microvascular fragments, which I'll be referring to as PMVF. We isolate PMVF along with while simultaneously isolating islets. And under culture conditions, we have noticed that PMVF exhibits extensive branching and proliferation. We hypothesize that PMVF can potentially induce angiogenesis in the intra-islet endothelial cells, leading to the formation of peri-islet vessels. This has a significant clinical relevance wherein co-transplanting PMVF with islet can rapidly induce inosculation with the host vasculature. Upon characterizing the cells, we found that CD31 positive endothelial cells are interspersed in islets. Endothelial cells are in red and islets are in green. Similarly, the vermiform structure of PMVF have endothelial cells in red in the core of the lumen, surrounded by alpha smooth muscle actin stained smooth muscle cells at the surface, as well as NG2 positive pericytes at the periphery of the vasculature. As a whole, they resemble a miniature blood vessel. Next, we wanted to study the behavior of cell-to-cell communication and cell interaction. We cultured them in hydrogel. Here, we use fibrin glue to provide them extracellular matrix support as well as extending their viability. And long-term goal was to integrate them into the clinic. So under islet alone in this hydrogel, when cultured for 1 week, showed signs of angiogenesis as seen by the red cells in the middle. The middle cell is the islets. The red stain are the endothelial cells. However, when islets were cultured with PMVF, after 1 week, we saw extensive angiogenesis as seen on the extreme right image. The red cells are the CD31 positive endothelial cells, which shows the signs of angiogenesis as well as formation of peri-islet vessels. In fact, these peri-islet vessels are formed all throughout the surface of the islets in the form of spikes. Next, we wanted to understand the mechanism between this angiogenic activity. So we explored the cytokines and as well as angiokine factors. And the early study shows upregulation of several of the cytokines, which possibly indicates macrophage-mediated angiogenesis, perhaps through paracrine signaling. We conclude that PMVF may have the potential role to induce angiogenesis in the intra-islet endothelial cells, possibly via macrophage-mediated angiogenesis through paracrine signaling. I thank the donor families as well as the organ procurement centers, without whose support we couldn't have accomplished this study. Thank you.
Thank you. Very nice presentation. Can you tell me how you would translate this to the clinic? Because if you're doing intraportal infusion, right, with these very tiny microvascular structures, how do they actually co-localize with the islet and have a benefit in the clinical setting if you've thought through that kind of next step?
Right. So still in the preliminary stage right now, but the long-term goal was to implant them at the alternate site, because if you put in the portal infusion, there'll be thrombosis. However, your team has presented the work about the poor outcome of omental pouch alternate site, but we have different strategies. We are working on it. So we have developing on other scaffold system through which we can co-culture and implant them. And still we have got some data, but we're a long way before we could take it to clinic.
Thank you. Very beautiful pictures.
Thank you.
I'm sorry if this is maybe it's not a fair question, but when you see those angiogenic vessels forming, do you actually see whether there's blood flow through it? Is there any way to actually check that?
So we have still done in vitro culture. This was under the co-culture of islet as well as microvascular fragment in a hydrogel. So we didn't have a scope to study the flow of blood as yet. Maybe in future we can consider that. Thank you for suggesting.
All right, thank you very much.
Thank you.
I just wanted to say before we introduce the next speaker that all the speakers are doing so well. Again, don't be nervous. This is like an elevator pitch. What would you tell someone, or what would you tell me if I met you in the elevator for about 2 or 3 minutes, if that's possible? And we are really encouraged by the questions. And so we do have 2 minutes for questions. So again, if you have questions, think of them and please ask them.
Thanks, Dr. Sohail. So our next speaker is Tarek Elslea from Advent Health.
Thank you. Good morning, everyone. Today we'll be talking about our systematic review comparing lactated ringers to normal saline for the prevention of post-ERCP pancreatitis. So post-ERCP pancreatitis occurs in approximately 8% of patients undergoing ERCP, and it may be up to 15% in high-risk cases. It can result in significant morbidity and mortality. One of the prophylactic measures is aggressive peri-procedural IV hydration, as it might minimize microvascular hypoperfusion. Furthermore, lactated ringers might actually be a better option than normal saline in these cases. This is due to inherent anti-inflammatory properties of LR demonstrated by multiple randomized control trials, where it was shown that there was a lower incidence of SIRS and lower CRP levels at 48 hours. This may be due to the lactate component of LR, which suppresses toll-like receptor 4, mediated inflammatory signaling, and other key inflammatory cytokines in the pathogenesis of pancreatitis. So we performed a systematic review that included all randomized control trials comparing the 2 crystalloids being administered at equivalent administration rates for ERCP prophylaxis, post-ERCP pancreatitis prophylaxis. Our primary outcome was the absolute risk difference in post-ERCP pancreatitis. We included 3 RCTs with a total of 594 patients. 2 of the trials included patients at moderate to high risk, and 1 trial included high-risk patients. Our primary outcome of post-ERCP pancreatitis was defined as abdominal pain consistent with acute pancreatitis, enzyme elevation more than 3 times the upper limit of normal, and prolonged or new hospitalization after ERCP. Our results showed a statistically significant reduction in the risk of post-ERCP pancreatitis in the LR group, with an absolute risk reduction of 4% and a number needed to treat of 25. Other adverse events, such as fluid overload, bleeding, and infection, showed no significant difference between the 2 groups. So the significant strength of our meta-analysis is a selective inclusion of randomized trials. It also showed a statistically and clinically significant result, while the individual RCTs included showed positive trends that were not statistically significant, meaning our pooling of data provided the additional statistical power needed to achieve significance. Some of the limitations is the limited number of studies, the small sample sizes of the individual studies, and some inherent baseline differences between the populations, such as risk of baseline risk, as well as other protocol differences in the hydration protocols. So in conclusion, LR reduced the risk of post-ERCP pancreatitis by 4% compared to normal saline, with a number needed to treat of 25. However, further large-scale trials are needed with standardized hydration protocols to validate our results. Thank you.
Thanks for sharing your results. And this may not be a question you can answer with 3 RCTs, but were you able to look at whether it mattered if fluids were administered before or after the procedure? I think there was at least 1 study where all the fluid was pre-ERCP. Is there a way for you to look at that?
Yeah, so with the limited data we have, we couldn't do such subgroup, and we couldn't do the subgroup analysis for that specific question. But for that individual RCT by Mock et al., where it was administered only before our ERCP, in that study, the risk difference was also 4%, the absolute risk difference, but it had a much smaller sample size than the whole data set, so it was not statistically significant. But it was around the same as our pooled results.
Yeah, just based on pathophysiology, that might be more impactful in prevention than post-procedure fluids. Thank you.
Thank you.
And may I also just clarify, did you, just your last slide, is it in the final results? I don't know if you can advance it further. If not,
This
the
one?
question was, you had mentioned that there was a reduction by 4%, or was it to 4%, meaning the absolute reduction in your overall trials
Yeah.
was 4%?
So the absolute risk reduction was 4%.
Okay,
It was an absolute risk reduction.
that's better than just by
Yeah.
4%.
The relative risk reduction was much higher when calculated. It was more than 30%, the relative risk, but absolute risk reduction was 4%.
All right, thank you very much.
Thank you.
And one other comment is, especially here, please, the junior people should feel free to ask questions. There's no question that's too basic or not important.
Thank you. So our next speaker is Nore Nishiwaki from Columbia University.
Thank you for the introduction. It is a great honor to be able to speak to you today. Pancreas has two functional compartments. I'll be focusing on hexacholine compartment, which is where pancreatic cancer largely originates from. The progression from normal pancreas to cancer often involves a series of changes, starting with metaplasia, advanced to dysplasia, and ultimately to cancer. And this process can be modeled in the mouse by injection of psolin, a cholecystokinin analog, to induce pancreatitis. Sorry. Although this process, progression from heliacinal cell to ADM to panning and ultimately to PDAC, is well established, the mechanisms driving tumorigenesis from an ADM state remain unknown. Previously, we conducted seal-time analysis using single nucleus ATAC-seq and found that FOSL1 and its related transcription factors regulate the transition from acinar cells to ADM. Because pancreas tissue contains abundant RNase is highly susceptible to degradation, and our previous protocol did not yield RNA of sufficient quality for sequencing. We therefore optimized the dissociation and sorting step to minimize RNA degradation and developed a new protocol compatible with high-quality single-nucleus RNA profiling. Then we applied 10x Genomics single-nucleus multiome sequencing, combined ATAC-seq and RNA-seq to capture both epigenomic and transcriptomic landscape within the same nuclei of pancreatic cells. Here, our multiomic analysis revealed distinct transcriptional and epigenomic signatures between acute and chronic pancreatitis, and we successfully integrated those two modalities. By focusing on genes that showed no changes in chromatin accessibility between two phases, we identified two distinct regulatory classes. POIS genes were minimally expressed during the acute phase, but strongly induced in chronic pancreatitis, whereas epigenomic memory genes were transiently activated during the acute phase. Interestingly, EMT-related genes belong to the memory class. These findings suggest that partial EMT contributes to the early adaptable response and highlight the decoupling between chromatin accessibility and transcription during acinar cell injury. To summarize, our new protocol minimized RNA degradation. Single nucleus multiome provides a powerful framework to elucidate the molecular basis of ADM and tumorigenesis. Thank you for your attention, and I'd be happy to take any questions.
You know, one of the questions as people are coming up, please. And I said, young people, we have our youngest looking member. No, please, I was just trying to make a humorous joke that you're so young looking. I just maybe while we're starting off, one question is, what is your protocol if you're allowed to share it?
So long story makes short, we changed mechanical dissection to enzymatic dissociation process, and also didn't sort the nuclei, but sort cell. So that is a big difference, but in detail, hopefully we can publish soon.
So, sorry, old person asking questions. So you shortlisted the 3 EMT related genes. So morphologically, or do you see changes in the acinar cell expression of EMT proteins, like a decrease in the epithelial markers and an increase in, say, vimentin or something?
Thank you for question. We actually didn't check those markers in the histology yet. We just recently add the normal and tumor state for those analysis and doing the analysis for whole stage. And afterward, I'm planning to see in the tissue.
Yeah, how did you define the memory and the poison genes? Like, what is your reference while deciding to look at those genes region?
So basic technique is actually analysis is done by the bioinformatician, and the basic concept is we compare the genes. Those are no difference between acute and chronic, and afterward we focusing on the RNA expression and see the difference in term memory and voice based on some previous publications. Thank you.
You know, please, there's a little more time for questions, but I would like to also ask you, again, this is so important, you know, the coming up with newer protocols. We've had multiple discussions at the APA offline with various people about, you know, how to really tailor to exocrine cells rather than just endocrine cells, where perhaps the first protocols may have arisen. And have you looked at or compared another method called fix and cut?
Yeah, I recently reached out the method fix and cut, but that is not my. I personally didn't do the fix and cut, but I'm really interested in that method. But also faced with there's quite different between the single cell RNA-seq and single nucleus RNA-seq, especially difficult to collect the good quality RNA. So that is a big issue I faced on, and maybe I can try fix and cut later.
Okay, can I ask you, after RNA isolation, were you able to culture them, or did you extract RNA immediately?
Sorry.
From acinar cells?
From acinar cells.
Did you culture them for a few days?
Oh, yes. So recently, yesterday, my coworker presented in the poster session, and we established a novel organoid protocol using this same protocol.
Oh, thank you.
Thank you so much.
Okay, our next speaker is Yixin Sun from Peking University First Hospital.
Good morning, everyone. Sorry I had a cough, but it's a real honor to share our work entitled Collagen Fiber Topology to Predict Survival in Patients with Pancreatic Cancer. Pancreatic cancer has a dense collagen-rich tumor microenvironment. In our previous study by Tim Yang from Peking University First Hospital, we found that collagen topology was characterized by aligned arrangement in PDAC and exhibited a more linear orientation with tumor progression. So could the topology or the structural arrangement of collagen fibers predict how long a patient will live after surgery? We studied 215 patients from Peking University First Hospital who underwent pancreatic cancer resection. A key metric we focused on was the coefficient of variation, or CV, of the fiber orientation angle. Think of it this way. A low CV value means the fiber are highly linearized and aligned like a bundle of straight straws. A high CV means they are more disorganized. So what did we find? After adjusting for all standard clinical variables, one feature stood out dramatically: collagen fiber linearization. Highly linearized collagen was a powerful and independent predictor of whole survival. It means 1.53 and 1.83 times higher risks of cancer progression and dying respectively. Predictive models incorporating collagen linearization showed excellent discrimination ability with AUC 0.86 for predicting 3-year PFS and 0.88 for 3-year OS. So collagen fiber linearization is a robust biomarker for predicting both PFS and OS in PDAC. However, a prospective cohort is required for validation, and a more accurate cutoff value needs a large sample size. Thank you for your attention.
Thank you. Those were really interesting findings. In a given tumor, did you sample multiple areas to see if it's consistently linear or not? So I guess my question is, can the orientation of the collagen fibers be variable across different regions of the same tumor? So that's first question. The second question is, when you adjust the hazard ratio, what are the factors you adjusted for?
Sorry for the second question. Pardon.
When you do a hazard ratio and then I think you showed us a adjusted hazard ratio. What are the factors you adjusted for?
The first question, we count the tumor issues about three layers or more, and measure the average value. Yeah.
So three different areas in the same tumor?
No, we just measure and calculate the average value. Sorry.
Yeah, that's okay. I'm just trying to get at whether the pattern you're studying is consistent or variable at an individual tumor level.
Like meaning if you were to individually look at each of those discrete lesions, is there variability among the lesions versus the average? Maybe offline. That's an interesting question to consider. I think Dr. Majumdar can talk offline about it. Maybe we'll talk offline.
Okay.
Yes.
Thank you.
Our next speaker is Emu Abu Sleiman from Johns Hopkins University Hospital.
Hello, everyone. It's my pleasure to be here. And today I'll be talking about the factors affecting compliance with pancreas surveillance. So some people are at high risk of developing pancreatic cancer, whether because of a germline mutation, a family history, or sometimes both. The current recommendations are regular surveillance with EUS and/or MRI. However, we noticed that some people are still missing their recommended appointments, even though they know that they are at high risk of developing such an aggressive disease with such a bad prognosis. So we wanted to see what are really the factors influencing compliance to pancreatic cancer surveillance programs, and is there anything we can do to change that? So we took into consideration some socio-demographic factors, clinical factors, psychosocial factors. We put them all together into a 21-item online survey. We sent it to via REDCap to all the HRIs enrolled in the CAPS-5 study at Johns Hopkins between 2014 and 2025. The survey was sent to a total of 996 patients. The response rate was high, the mean age was 65, and the reported compliance was really high. So three big categories of factors that were assessed are sociodemographic factors, clinical and genetic factors, psychosocial factors. I listed them all here. We ran a univariate analysis, and some sociodemographic factors that are usually associated with compliance to other type of cancer screening, like colorectal or breast cancer, were not associated with compliance to pancreatic cancer surveillance. And so what turned out to limit the compliance were personal work-related challenges, significant insurance copayments, and fear of finding cancer. On the contrary, what pushed people to comply with their recommendations was an emotional response, whether reassurance or anxiety, having a good support system, preferring EUS over MRI as a surveillance modality, and finally, having undergone genetic testing, whether the test was positive or negative, did it influence their compliance. The main motivation reported by our participants was to detect pancreatic cancer at an early stage, and this was an intrinsic motivation when compared, for example, to a recent PDAC diagnosis or the death of a loved one, which is an extrinsic motivation reported by only 12.3% of the participants. Our participants also had the chance to further elaborate on what motivates them, and the qualitative findings confirmed our quantitative findings. And so there's a critical role of psychological support within surveillance programs. Integrating genetic risk assessments may be a valuable strategy for identifying and retaining HRIs, and there's a strong desire for motivation for innovation in surveillance modalities. Thank you.
All right, I got a quick question. Thank you for the great talk. So I was curious, how did you identify those high-risk individuals? Is it through a study that you have, you manually identified them, or?
The high-risk individuals?
Right.
Yeah, so the CAPS-5 study, it's a study that has been ongoing at Hopkins for a lot, like more than 20 years now. And we enroll patients that come for endoscopy if they have a family history of pancreatic cancer or if they have a germline mutation. And then they're part of our study. We have them on our REDCap and our records, and we have their emails, etc. And so we identified all the HRIs that we have and we sent the questionnaire.
Hi, great talk. I don't know whether I missed the slide or didn't look at it properly, but there would seem to be a difference between the responses or the between males and females, the compliance. Quite a big difference, I thought. So I was wondering whether there's any way to change that or.
Yeah, this is not the compliance between male and female. It's just how many.
What's the response to survey?
Yes.
Okay, sorry, I missed that. Is there any way to change that, I guess, is the question.
Yeah, so unfortunately, I don't think so because most of our participants enrolled in CAPS-5 study are females. Yeah, we have more females than males in general, but this didn't affect the compliance.
Yeah, also in their preferences, they preferred EUS over the MRI. Have you thought about why it would be? Because MRI is non-invasive. Like EUS is also non-invasive, but MRI is less invasive than EUS.
Yeah, very valid question. We thought that maybe it's because people who prefer EUS are more, they want to have surveillance and they're more prone to just accept whatever it takes to undergo surveillance because they prefer already EUS over MRI, and so they tend to be more compliant.
Thank you very much.
So our next speaker is Crystal Mills from Mayo Clinic.
Good morning, everyone. I'd like to thank the APA for the opportunity to present our team's work on subtype-specific malignancy risk in autoimmune pancreatitis. So as we all know, chronic inflammation increases the risk of pancreatic cancer, and autoimmune pancreatitis is a chronic fibroinflammatory disease of the pancreas. However, cancer risk in AIP remains poorly understood. In this study, we aim to assess AIP subtype-specific cancer incidence, including associations with relapse and age at diagnosis. This was a retrospective single-center cohort study of patients with an AIP diagnosis between 2000 and 2023. We included patients who were above 18 years of age and who met the ICD-10 criteria for type 1 AIP, type 2 AIP, or AIP not otherwise specified. We excluded patients with a personal history of pancreatic cancer and pancreatic surgery. This yielded, for a primary outcome, new cancer diagnosis, pancreatic and extrapancreatic, and this was analyzed using Cox proportional hazards models as well as incidence rate calculations per 1,000 person years. We did multivariable adjustments for age, sex, and relapse. This yielded a total of 282 patients, of which 199 had type 1 AIP, 64 had type 2, 19 had AIP not otherwise specified. For demographics, AIP, patients who had type 1 AIP were older and more likely to be male compared to type 2 and AIP not otherwise specified. There was no difference in ethnic or racial distributions among subtypes. Type 1 AIP patients had a higher rate of current or former smoking history. There was no difference between alcohol use or BMI. Type 1 AIP patients also had a pre-existing diagnosis of non-pancreatic malignancy more often, as well as a prior history of AIP treatment with immunomodulators. In regards to overall results, type 1 AIP patients had the highest number of cases, and this corresponded to a 3.5-fold higher incidence in type 1 compared to type 2 AIP. Incident pancreatic cancer only occurred in type 1 AIP, of which we identified 3 cases. Extrapancreatic cancers were the predominant cancer types among all subtypes, with prostate cancer occurring exclusively in type 1. Renal cancer was more common in AIP not otherwise specified, and the other extrapancreatic cancers were not significantly associated with AIP subtype. We looked at disease relapse patterns to see if this had any influence on the malignancy risk. As you can see, by the time we got to 15 years, relapse-free survival decreased to 32% in type 1 AIP compared to 78 and 83 in the other subtypes. However, relapse was not significantly associated with cancer risk. Age at AIP was a risk factor, and the difference in malignancy was driven by the differences in age distributions. So in conclusion, extrapancreatic cancers drive the overall risk. There's no increased risk after relapse, and this is an opportunity for further studies. I'd like to thank my research team and thank you all for listening.
I think it's really valuable, but even we don't know like how chronic pancreatitis is related with the increased risk of ratio in pancreatic cancer. So have you checked the patients any germline mutation for the those cancers for renal? For prostate, no, but for the renal cancer.
Yeah, so for this cohort of patients, we haven't done genetic testing. We've done it with our chronic pancreatitis patients, but not for the autoimmune cohort.
Hi, very nice. Quick question, and you might have been getting at this, but so the difference between type 1 and type 2, is that driven by the age and the male predominance then? Is that your kind of conclusion?
That's what we're seeing, yes. Thank you.
And one question I would have is, and maybe I missed it, but the bigger question from these data, I guess, if I was to ask was, is there an increased risk of PDAC in autoimmune pancreatitis related CP versus CP that's non-autoimmune related? Is that one of the questions that you're asking, and do you have a conclusion about that?
Yeah, so based on our cohort, it's about equivalent to what we have in the existing literature for chronic pancreatitis. So chronic pancreatitis is about 1 to 2%. In our cohort for AIP, it's about 1 to 2% as well. But given our overall numbers, we'd like to do kind of multi-cohort, multi-center studies to validate those findings specifically, yeah.
Okay, our next presenter is Chen Kai from Peking University First Hospital.
Great pressure detail, non short. TREM2 has more recently emerged as a pro-tumor genetic marker of tumor-associated macrophage and a promising target for enhancing anti-PD-1 efficacy. However, the role of TREM2 in PDAC remain largely unexplored. So we want to focus on the tumor macrophage change after the neoadjuvant therapy. We found a significant increase in the proportion of the TREM2 positive M2 macrophage following neoadjuvant therapy. Notably, age-treated patient has exhibited higher level than who received the FOLFIRINOX, and the KM curve show indicated KM curve show indicated that the patient with low proportion of TREM2 positive M2 macrophage had a longer overall survival and recurrence-free survival. So the explanation of the TREM2 positive M2 macrophage following neoadjuvant therapy allows to hypothesis whether combined anti-PD-1 and anti-TREM2 immunotherapy can improve the tumor response, and receiving the combination immunotherapy showed improve tumor control and longer survival. So we harvest the tumor after 40 days the post inflammation. We found a significant increase in the M1-like tumor phenotype, but reduced M2-like phenotypes. So this result suggested TREM2 can reverse the immunotherapy-induced macrophage, impressive macrophage by reprogramming M2 macrophage to M1 macrophage. And very interesting, we also identify a unique cell population co-expressing TREM2, FAP, MSA2. So that is the AP-CAFs. And we found a very interesting result that is the TREM2 can reduce the TREM2 positive AP-CAF and increase LRC15 positive MyCAF. So in summary, TREM2 M2 macrophage explain following neoadjuvant therapy and are associated with the poor clinical outcome. Second, anti-TREM2 treatment, potential anti-PD-1 immunotherapy. Third, an anti-TREM2 treatment reverse the chemotherapy-induced M2 polarization following reprogrammed tumor-associated macrophage. And last, anti-TREM2 can directly regulate CAFs. So thank you for your attention.
Bhumi Lee from Stanford. So you might heard the second talk who discovered TREM2 knockout mice accelerate the pancreatic cancer. What do you think about this discrepancy?
Actually, next time we want to do the TREM2 lockout mouse experiment, and I think there's a difference between the TREM2 antibody treatment and the TREM2 lockout. There's so we don't collect the results, so I can't answer here. I think there's a difference. Interesting research about crosstalk TREM2 between macrophage and CAF. I want to ask, I see 3 drugs you use in vivo. I want to know the drug toxicity and safety.
Yes, we use gemcitabine to minimize the neoadjuvant therapy in the clinical setting like AG. So because we found the AG treated patient had a very high level of TREM2 positive M2 macrophage. So we use the gemcitabine to minimize the neoadjuvant therapy. And also because most of the study found the anti-TREM2 treatment can enhance the efficacy of the anti-PD-1 treatment. So we hypothesis, can we combine the anti-PD-1 and the anti-TREM2 to improve the tumor control in the neoadjuvant therapy setting? So
Just in time. Thank you.
Was at 11:15, but we haven't got your slides up here.
You just check with them.
Yeah.
Maybe I just before we start, I think, again, I hope everyone's enjoying this. This is our first time, so please give us a little bit of grace. I think there's one person whose slides needs to be in here, Dr. Khasima Hafiz. So if you can please just go to the AV group and ensure that your slides are maybe at the end before Dr. Yang. And then we'll go to the next speaker. And here, I'll give it to you to introduce.
Thank you. So our next speaker is René Manke from Brandenburg Medical School, Germany.
Hello, everybody. From lab research to clinical reality data. It's a pleasure for me to present you our study about pediatric pancreatic surgery, a population-based study in Germany. Why we are discussing this topic, we have some single center analysis, but all with small case numbers demonstrated superior results in pancreatic surgery for children. But we have no population-based data at that time. And we analyzed German DRG data, routine data from 2010 to 2023. And we found 761 patients, children with pancreatic surgery. What are the results? A few to the diagnosis, we found mostly chronic pancreatitis, some type of chronic pancreatitis. There was 37% of the patients, followed by pancreatic tumor, 29%, and followed by pancreatic trauma, 16%. What are the procedures? The most procedure was the distal pancreatectomy with 36%, followed by pancreatic duodenectomy, followed 16%. We found that 183 hospitals did pancreatic surgery in children. This is about 20% of all hospitals in Germany. They did pancreatic surgery in that time. And you can see for pancreatic tumor, we had more female patients, 70%. And for pancreatic trauma, we had more male patients, 63%. And look to the mortality, we have an overall mortality of 2.8%. And for pancreatic tumor, we found 0% mortality. For chronic pancreatitis, 2.8, for trauma and extrapancreatic neoplasm, 2.5, and for other, 11 point. Other means mostly congenital malformations and some time of acute pancreatitis. We found 0 complications in about 58% of all patients, and we found that no need of any blood transfusions in about 66% of patients. Let me give you a conclusion. We did the first population-based study of all pancreatic surgery cases in children in Germany. Indications were mostly chronic pancreatitis and pancreatic tumor. Procedures were mostly distal pancreatectomy and pancreatic duodenectomy. And we found 41.8 9% complication rate, some risk factors in the multivariate analysis for complications, and 2.8 mortality rate, which is much smaller than for population-based analysis in adults. Thank you for the attention.
Well, let me just ask one question at least, which is very interesting. Thank you for these data. How does this compare with equivalent adult surgical patients?
We found for adult patients, when we use population-based data, mortality rates from 10 to 12%. It's much higher in relationship to single center data, like in the US, or single center in Germany too, from the Heidelberg group. And we found 2.8 here, but we think we can reduce this with a more concentration, because 180 hospitals is a quite number of hospitals that did pancreatic surgery in children.
Can I ask a question? Wonderful data. So of course we don't have this much. I mean, most of North American data is going to be TPIT, not much distal pancreatectomy or pancreatic duodenectomy in the kids. So can you tell us like what kind of tumors and require that kind of surgery, and what is the long-term outcome? How did they do with the pain and recurrent attacks of pancreatitis? Would love to know a little bit more about the long-term outcome.
Yes. I can you give no information about long-term outcome, because these are data for diagnosis-related groups. And we have only a few in the hospitals, not the follow-up. The data will not give this.
Okay, thanks.
Sorry.
I also wondered, like, what are the histological type and the pathological confirmations of pancreatic tumors in the pediatric population?
Yeah, we have no information, especially or besides the ECD10 classification. We use data from the ECD10 classification, and so this is a lack of data, of course. Thank you.
Our next speaker is Sahar Naseem from Dana-Farber Cancer Institute. Thank you.
Okay, thank you to the organizers for this opportunity. My name is Sahar Naseem. I'm an assistant professor at Brigham and Women's Hospital. There we go. So I'm going to show you new findings in acinar to ductal metaplasia that we made using a novel single-cell method that we developed in our lab. So as was already mentioned, single-cell study of the exocrine pancreas has lagged that of other organs because of endogenous digestive RNases and proteases. To mitigate this challenge, we developed a method called fix and cut, whereby tissue is immediately and reversibly fixed before it is cut and dissociated into single cells. The cross-linker DSP diffuses into cells and completely shuts down RNase activity. After dissociation and encapsulation into droplets, the cross-linking is reversed, allowing library preparation from single cells. Fix and cut significantly outperforms other methods in recovering acinar cells and in quality of transcriptomes. You can see this benchmarking in our publication. We anticipate this method will be broadly useful for the field and will help advance exocrine pancreas research. We leveraged fix and cut to study ADM in the following mouse models: acute pancreatitis, recurrent acute pancreatitis, chronic pancreatitis, and acute pancreatitis in the context of an oncogenic KRAS mutation. We analyzed over 300,000 cells across these diverse conditions. This UMAP shows all these epithelial cell states across multiple stressors and their evolution over time. Normal acinar cells in teal are the predominant population in the control pancreas, and these then elaborate different responses to diverse stressors. The first surprising observation: in the first 3 days following acute pancreatitis, acinar responses are the same whether or not an oncogenic KRAS mutation is present. After 3 days, the responses diverge dramatically. Without oncogenic KRAS, the acute ADM response resolves back to these teal acinar cells by 14 days. With oncogenic KRAS, we see emergence of additional more advanced metaplastic states and progressively more pannins, shown here in brown, which make up the majority of epithelial cells by 12 weeks. Here's an overview of these advanced metaplastic states we see across all conditions. There's lots of information here and I won't cover it. I'll just highlight a few vignettes. One new metaplastic state is a population we're calling gateway ADM or GADM because it marks an inflection point in the metaplastic continuum. The GADM state demarcates populations that retain strong acinar identity and subsequent populations that acquire malignant transcriptional programs. We confirm the presence of this new metaplastic state by cosmics of spatial transcriptomics of human pancreas. So why do gateway ADM cells progress to advanced ADM states in the presence of KRAS, whereas without oncogenic KRAS, they recover normal acinar identity? Well, only in the presence of oncogenic KRAS do we have strong activation of transcription factors, chromatin remodeling genes that promote plasticity to dynamic preneoplastic states. And we also see tumor suppressors that we believe are reactive to initially restrain cancer formation. I'll skip this slide. One last surprising observation, Pannin cells clustered into classical and basal subtypes that have been reported in advanced pancreatic cancer. And this dichotomy has never been reported before outside the context of cancer. We validated this classical versus basal dichotomy in our mouse Pannins as well as by cosmics. And you can see individual Pannins harbor both cell types, mutually exclusive cell types. Here's a summary of the findings, and I'll now take questions. Thank you. And Sohail, to your question earlier, yes, we did compare this to NucSeq as well as the 10x Flex FRP platform, and it's I think the other speaker, I don't know if he's still here. With
Can you just
NucSeq,
speak up in the microphone?
Sorry.
Can you speak up in the microphone?
Closer. Oh, sorry. I think with the issues with NucSeq, the depth of the transcriptome that you get from nuclei it's challenging to discern a lot of different cell types, and it's mostly biased to nascent transcripts, which sometimes may mask, and it's harder to discern different cell types. And we compared this to the 10x Flex kit as well. I don't have the data here, but I can show you offline.
Yeah. Okay, I'm Xunjun Xiao from Washington University in St. Louis. First of all, wonderful work. So I'm just curiously we know it's very challenging to study single nuclear, especially mouse pancreatic tissue. So for you, when you do this kind of assay, how big are the tissue you guys are using, or this specific assay?
Yeah, it's in our paper. It's up to 3 by 3 millimeters. It's a very small piece of pancreas.
So have we ever scaled up? Because what I'm worried about is the heterogeneity of the mouse pancreas.
So we've tried to scale up, and it's a great point, because you could say, well, you have sampling bias, and if you sample, and there have been times where we unintentionally pick up a lymph node, and that totally biases, and you can see it in the single cells. But we've tried with larger tissue. The problem is, how quickly can you diffuse your cross-linker? And so there's a trade-off, and there's a sweet spot that we find.
Okay, yeah. Thank you.
And let me just say, we have time for just 2 brief questions. So please, brief.
Great talk. I think the fix and cut shows a very impressive improvement in single cell acinar cell identification and subsequent, RNA-seq. But that raises a question for me. Maybe I might have missed it if you did compare head-to-head with a conventional technique?
Yeah, in our lab with the same hands, we compared it to, but yes.
Leading to the follow-up question, did it cause you to obtain different results with respect to immune cells?
It's a great question, and you can see in our paper published in Gastro that we did look at immune populations, fibroblasts. There's a ton of data, and so we do have much better capture of traditionally challenging populations, including macrophages, neutrophils. Yes, and challenging for the same reasons of high RNase content, as well as the milieu of high digestive enzymes.
So I imagine other groups that have relied on conventional methods and made broad conclusions about the immune cell populations, they might need to revise their conclusions.
Yeah, I mean, this isn't a panacea, but I do think this is a significant improvement and hopefully opens up new directions. And we have a paper that a lot of this stuff is going to be hopefully published soon, but there are new metaplastic states. I skipped over one that has a neural.
Sahar, I'm
Oh,
sorry to cut you off, but
you.
you do have one brief, but Elif, please,
Yeah.
brief and no counter response.
Yeah,
And we can talk offline.
You showed the heat maps both in human and mouse. Those are for the just to validate your methods in healthy animal and healthy human data, or in the any panin patients.
It's a great question. So the mouse models are without cancer. The human samples are normal adjacent, and that's a really important question. So, Eileen Carpenter's paper from Marina Pasca de Magliano's lab looked at pannins from cadaveric samples. They never saw the basal type in pannins without cancer. Here we're seeing both classical and basal that's never been reported before, and it's in mice without any cancer. Yeah.
All right.
Yeah.
Thank you very much.
Thank you.
The best part about a meeting is the Q&A, and I think the success of a meeting is engagement, Q&A. In this session, obviously, it's much shorter, and these are such important topics. So we do have, I believe, about at least 3 more talks, and one of them, I think, was added from a previous session due to some glitch, so we may have to give them a few more minutes, but we are doing very well and nearing the end.
So our next speaker is Yasu Zhang from Songda Hospital.
Good morning, everyone. Today, I will present our research on identification of metabolic characteristics of and differential diagnostic biomarkers for type 3C diabetes based on untargeted metabolimics. First, type 3C diabetes key clinical features is the impairment of both endurance and exurance functions of the pancreas. Surgically, the incidence of T3CDM has not surpassed that of type 1 diabetes, making it the second most common type of newly diagnosed diabetes in adults. A major cause of T3CDM is post-pancreatitis diabetes mellitus. With the update of the guidelines, T3C diagnosis and screening has been elevated to an important position. PPDM, following accurate pancreatitis, lacks specific biomarkers, which leads to an unclear screening method and diagnostic standard. Therefore, the aim of our study was to use untargeted metabolics to delineate the unique metabolic characteristics of PPDMA and to identify discriminative biomarkers that can distinguish it from common diabetes subtypes. And we enrolled 194 participants and conduct comprehensive quorum metabolomic profiling using UPLC-MS. Our analysis revealed several key findings. First, when comparing PPDMA with healthy controls and with accurate pancreatitis patients, 3 conserved general glucose for specifically diabetes emerged as current biomarkers. Pathway analysis highlights glucose facilitated metabolism and oxidized stress. Next, in the comparison with type 1 diabetes, lipid metabolism demonstrates the significant feature. A biomarker panel derived from Lasso regions showed exponential distinguished power. At the same time, two lipid species achieving an AUC greater than 0.9. Similarly, in the comparison with type 2 diabetes, lipid metabolites were again a key. Our composite biomarkers panel demonstrated high diagnostic efficiency.
I think you may need to wrap up if possible.
Okay. The pathways involved such as glycerol phospholipid metabolism and terrain metabolism impact during extraordinary and enduring injury and inflammatory pathogenes in PPDMA. And in conclusion, our study demonstrates that PPDMA is crystallized by glycerol phospholipid demonstrate coupled with oxidized strength and disrupt of pancreatic exporting and endurance crosstalk. That's all. Thank you.
Just a brief comment. That's really nice work. Sometimes the trouble with pioneering a new methodology is like you don't quite know what to make of the results for a while. But I think with some thought, you'll be able to understand better what this means.
Oh, yeah. Thank you.
Okay, thank you very much.
Next slide, please. Okay, so our next speaker is Jianlu Zhang from Peking Union Medical Center.
Good afternoon, distinguished chairs, colleagues, and friends. It's a great honor to present our work today. As we all know, RBD's complexity creates a steep learning curve. However, the role of the assistant has been largely neglected. Lack of standardized team-based protocols defining the synergistic roles of the consult surgeon and bedside assistant. Consequently, to bridge this gap, our objective was to describe a comprehensive team-based SOP for RBD. Sorry. This study was a single center, single arm, retrospective cohort study from October 2022 to August 2025. Totally, 71 consecutive patients was included. All procedures performed by our team adhering to the SOP. This is our standardized operating room layout. This layout it's more comfortable and can reduce unnecessary step movement, reduce fatigue of assistant and scribe nurse. This is our standardized port placement. This is our standardized instrument configuration, reduced variety for cost efficiency. This is our standardized docking configuration. And this is our standardized and unique resection sequence First of all, the division of the laser omentum and the division of RGA and the GDA to control the blood supply, and then cholecystectomy and the dissection of inferior pancreatic neck, and mobilization behind the pancreatic head, and then transection of pancreatic neck, and then division of onset process, finally digestive tract reconstruction. In the result, the mean operation time was 365. Surprisingly, the median blood loss was remarkably low at only 50. In addition, the 30, I'm so sorry, I need 2 minutes more.
May I ask you if you can just give us the concluding point
Okay.
and skip
you.
over your results?
Thank you. In conclusion, validated team-based SOP versus multi-institutional benchmark in surgical efficiency, we are on par with leaders. In hemostasis, we are superior. In major complications, we are on par with leaders. In mortality, we are 0. That's all. Thank you. Thank you.
All right, thank you.
Thank you.
And we have 2 more speakers, and the next speaker, I understand, is from a different session. So they will have a few more minutes, but please keep to your time, and we won't have time for Q&A because of our time crunch. And we have one last speaker who will be part of the rapid fire. I will pass to Dr. Shaman.
Okay, so our next speaker is Julianne from Mayo Clinic, Florida.
Thank you so much. And hello, everyone. It's my great honor to give my presentation in this fantastic APA conference to share about our work. Thank you. So I have nothing to disclose. And for the background from the Olmsted Country Registry, we see a clear increase in IPMN incidence over time. But from SEER data, the rate of IPMN-derived carcinoma has not really increased in literature. And at the same time, we see that CT, MRI, and US also report like very relatively high detection rate, which may explain the trends of detection of the incidence of IPMN. And in our own data from Mayo Clinic, all 3 sites, we've also seen more patients diagnosed with IPMN in recent 20 years. We are now seeing many more like IPMN patients, especially those with low-risk BD-IPMN. So understanding the natural cause of low-risk BD-IPMN is very important. There are some great studies together include about 8,000 BD-IPMN patients with around 2.5% malignancy risk at 5 years, and about 2,000 patients with 6% risk at 10 years. But these cohorts were under intensive follow-up, so could the true rate in the real-world population, especially low-risk ones, be even lower? So we want to revisit this question using the Mayo data in Florida, which provides a relatively large real-world data set. And also we are going to use some new techniques as the AI to help us in the process. We built a large language model pipeline to read radiology reports along with other clinical information. And this is to help differentiate BD-IPMN from other IPMN or non-IPMN, and then to classify each case as low-risk worrisome feature or high-risk stigmata based on a guideline. This approach allows us to process a large number of records efficiently. And after 2 rounds of manual validation, the model reaches about 84% of overall accuracy by 2,000 records check, with the best performance in the low-risk group. Because because our goal was to answer clinical questions, so we wish the results to be like more precise. So we added some logic check steps to flag uncertain or inconsistent records. And these were manually reviewed for about 5,500 records to improve reliability. In total, we screened 63,000 radiology records from 11,000 patients and integrate additional clinical information. Finally, we identified around 7,000 patients with BDIPMN, and among them, 6,300 were low-risk BDIPMN patients, and over 1,000 followed for more than 5 years, and nearly 300 followed over 10 years. And if we say the Sankey's plot, it shows how the risk status change over time. As you can see, most low-risk patients stay low risk, even after following them up for up to 10 years. And for the progression rate, first, let me explain a little bit about some definition, because we sometimes see the risk status change back and forth sometimes. So we counted both the first appearance of worrisome feature and high risk status, and also the like stable appearance ones, which means those without any later regression to low grade. And you can see an example at the bottom of this slide. So at 5 years, even we calculate the first show, it's only about 9% of low-risk patients develop worrisome feature and around 5% develop high risk. And by 10 years, the stable show rate were 14% and 8% respectively. And importantly, in the entire low-risk cohort, only 11 patients eventually developed carcinoma, which is less than 1% of all BDIPMN patients we followed up. So, and despite clear international guidelines, we found that the follow-up adherence was still suboptimal. About 40% of low-risk patients did not follow the recommended surveillance intervals. And with our structured data, however, it became much easier to identify patients who truly need follow-up. For example, we could directly find 15 high-risk patients in 2023 who had no follow-up in the following year in 2024. Our main strength of this study is this relatively large cohort in the real-world setting, with many patients followed for over 10 years. And definitely there are a lot of limitations, includes loss of follow-up and incomplete outcome data. And since AI, another thinking about this is since AI doesn't show where it makes mistakes, we may need better strategy to verify the outputs and reduce uncertainty. And in the future, we will try to expand this strategy to all 3 male-sized data and continue to optimize the model. So this is a summarization of the take-home message. And at last, I would like to thank both Dr. Wallace and Dr. B's team, all of the team members in the Mayo Clinic, and our collaborators, as well as PUMCH, who sent me here to provide me the opportunity to study here. And also, I would like to thank the great APA conference, as well as the APA fellowships symposium this year, earlier this year in Orlando, that bring me quickly into this society. Thank you very much.
Thank you so much.
Thank
No, please.
I'm sorry. Yeah, we can communicate about that. Thank you.
Sorry about that. Yeah. Thank you. So our lucky last speaker for the rapid fire abstract session is Kasima Hafiz from Baylor All Saints.
Hi everyone, I'm Hazima. I'm internal medicine PGY3 at Baylor All Saints, and I'm presenting a rare return recurrence of insulinoma 18 years after surgical resection. I have no disclosures. Learning objectives are to recognize the clinical presentation of insulinoma, understand the diagnostic workup, and analyze the diagnostic challenges and delays, and discuss the management of insulinoma. An insulinoma is a rare yet a common functional neuroendocrine tumor with an estimated incidence of 1 to 4 cases per million people per year The diagnosis is often delayed due to rarity of the tumor. A 72-hour observed fast is the gold standard for diagnosing insulinoma, and surgical resection remains the cornerstone of treatment. So I present a case of an 86-year-old female with past medical history of recent intracranial hemorrhage and insulinoma status post-resection in 2007. She presented with new onset right-sided weakness. Vital signs on arrival were notable for a pulse of 107 and respiratory rate of 27. On physical exam, she was aphasic. She had strength of 3 out of 5 on the right upper extremity and 4 out of 5 in the right lower extremity. Her labs were grossly unremarkable. Her blood glucose on arrival was 78. However, she did have several episodes of hypoglycemia prior to arrival. CT had showed no acute intracranial abnormalities. So here's her hospital course. So day 1, she was admitted to the hospital. Day 2, she continued to have hypoglycemia with adequate oral intake. Her blood glucose dropped to 48. And on day 3, we obtained modified hypoglycemia testing. Her serum glucose was 66. Her total insulin was inappropriately normal at 19.9. Pro-insulin was elevated at 22, and beta hydroxybutyrate was 0.4. On CT, abdomen and pelvis, her pancreatic showed pancreatic tail resection and changes with dystrophic calcification, bulbous appearance of the pancreas, and a 9 mm mass on the pancreas. On day 12, she had EUS with FNA and surgical pathology showed well-differentiated neuroendocrine tumor. On day 23, after multiple extensive discussions with the family, they decided to transition the patient to hospice, and she was discharged. Here's CT abdomen and pelvis showing nodular density concerning for insulinoma indicated by the arrowhead. So in conclusion, an insulinoma is a rare neuroendocrine tumor of the pancreas. Hypoglycemia may be misattributed to other causes such as medication side effect, malnutrition, or critical illness. Recurrent hypoglycemia should prompt investigation, and it's crucial to maintain clinical vigilance for insulinoma. The diagnosis of insulinoma involves comprehensive evaluation of clinical symptoms, lab tests, and imaging studies, and surgery is the mainstay treatment for insulinoma. Thank you.
Well, you're entitled to one question, but that's okay. Because you were actually part of the session. So again, I apologize if we had to be very strict on the time, and at times we were not allowed to ask questions. I will say that in this type of forum, which is again becoming more common, less is more. Give us the highlights. What do you do for a living? What's your most important point? What are the 2 big things that you've discovered? And we'll hopefully do more of this. I want to thank my moderator, Dr. Perara, and to the audience for staying this long. This has been a wonderful APA, and we are now nearing at the end, actually, and I'd like to pass it to Madam President, Dr. Bellin, as well as Dr. Saluja, our Secretary Treasurer, and let's get a round of applause for all these great presenters.
Actually, Sohail, I believe it's Mr. President now, so pass the gavel to you, but thank you for everyone who attended and stayed for the entire session. We really appreciate the audience engagement and meeting our colleagues and friends here.
I really want to first thank both the co-chairs of this session for being very efficient, keeping the time and running very well the last session. And I am really impressed that we still have many brave souls here after 3.5 days of intense pancreatology. But I really want to congratulate Madam President for a job very well done. Great meeting. Great job. And of course, we want to welcome Mr. President. And I'm sure you're going to do a great job and look forward to working with you. But I want to come back to Madam President and just want to make sure that now onward she's past president, but that does not mean that she still is going to contribute, be part of APA for just about 25 more years. After that, she can leave.
Yes, I will be here for another 25 years, I hope.
Thank you very much. Well, As president, I officially close the APA meeting.